So today I'm going to be talking about fibroids and bleeding. It's something that comes up a lot, and thank you for your questions today. One of the commonest side effects of HRT is actually bleeding, and it can cause a lot of confusion for women as well as healthcare professionals, so I hope I'll be able to unpick some of that. But I also wanted to touch on fibroids because it's Fibroids Month this month in July, and I hope that you've listened to the podcast I did with Mr. Azami Naji on Tuesday. It came out this week, so you can find it, you can download it and have a listen, or you can watch on my YouTube. Now, fibroids are very, very common. They're far more common than actually we thought, but often they don't cause problems. They're not always associated with bleeding. I'm not a gynecologist, I'm a general physician, so my knowledge is not as good as Ozami's, so it's definitely worth listening to him. But fibroids are small growths. They're not cancerous, they don't change to cancer, and they grow in the lining of the womb, or they can grow in the wall of the womb, or they can actually grow just a little bit outside as well. So they can go in any of the layers of the womb, if you like. And sometimes they're very small, sometimes they can grow quite large. Sometimes people only have one, and sometimes people have multiple fibroids. Sometimes they can cause symptoms, and sometimes they're an incidental finding, which means they're just found maybe because someone has a scan, or they might have some symptoms and then they're found. But it doesn't mean that they're the cause of all the symptoms that you are experiencing. Now, I was always taught when I was at medical school that fibroids shrink after the menopause, therefore estrogen makes them grow. But there isn't really amazing evidence to show that, and we don't actually know why some people are more prone to fibroids than others. They can be more common in some racial groups, and they can be more common as we age, but some people get them for no reason. We increasingly in the clinic see people who've had fibroids, and they also might have endometriosis, they might have polycystic ovarian syndrome, and some of us are wondering, could it be related to not having enough progesterone or even testosterone? We just don't know because the studies haven't been done. Now, they can get smaller during menopause, but they cannot as well for some people. Some people have also been taught that if you have fibroids, you can't have HRT because it will make them bigger, make them bleed, and there's no evidence for that either. And actually, some people find that they tolerate HRT very well despite having fibroids. HRT, as you know, is only 3 letters. There are different doses, there are different types. Often it's important to have the right dose and type to really make sure that your symptoms improve, but also they can help with fibroids as well. So if you have had fibroids and been told you can't take HRT, that's not actually right. So fibroids can cause bleeding for some people. They can also cause pressure symptoms as well. So you can imagine if you've got a fibroid that's grown quite large in your womb, it might be pressing forward, so it might be pressing on the bladder and causing problems. You might just have some discomfort, feeling that you've got some heaviness or dragging in the womb, which might be related to the fibroid. And sometimes people can have some bowel symptoms as well. Less common, but it depends on whereabouts the fibroids are. Having fibroids doesn't mean that you're going to be infertile. Again, it depends on the position of the fibroids. And some people have managed successfully to get pregnant, and the fibroids have been there and not had any effect on the developing fetus as well. So it really varies. It's important, if you have fibroids and you think they're causing symptoms, to discuss treatment options. And there are lots of treatments for fibroids, and increasingly there are different treatments, so it's worth speaking to someone who's a specialist. Clearly they can be removed, and sometimes just the fibroid is removed, or the fibroids, depending on where they are, of course. Sometimes people actually have the womb removed with the fibroids in, if that's the best option for them. And then there are treatments such as a uterine artery embolization, where they stop the blood supply going to the fibroids, and then the fibroids can shrink. And that can be done in specialist centres as well. Some people are given hormone blocking drugs to reduce the size of the fibroids, but the problem with that is that they can or they will induce menopause, and they can cause a lot of symptoms. So if you are being offered an injection for fibroids, find out exactly what it is and find out if it is going to lead you to be menopausal and if you are going to be offered any add-back hormones as well. So it's definitely worth asking the right questions about fibroids. It's important that if you have been diagnosed with a fibroid, that the specialist can talk to you about whether it's causing symptoms or not, because sometimes I see people in my clinic who have been told, I'm having bleeding because I have a fibroid, and it might be that they're having bleeding because they're not on the right dose and type of hormones. It's very easy to blame something when you found something on an investigation, but as with anything in medicine, it's really important to take a full history, talk to your doctor so that they have the full picture of what's going on and can try and work out if the fibroids are related, because what you don't want to do, of course, is have treatment for the fibroid and then find that your bleeding's continuing or your other symptoms. So make sure there's no other reasons for any of the symptoms that you have attributed to your fibroids. I hope that makes sense. Certainly it's worth listening to our podcast in a lot of detail. It's only half an hour, but it's worth listening to so you can find out more about fibroids. But all I really wanted to say is, firstly, fibroids are very common. They're not cancerous. They don't always get worse when people take HRT, and certainly having fibroids is not a contraindication to having HRT treatment. Now, you all know, I'm sure, that the benefits of taking hormones do outweigh any risks, and it's important to have individualised advice, support, information and treatment from someone who really understands what hormones are and what they do. Now, I'm going to spend the next 20 minutes really talking about bleeding. I have done an Instagram live before about bleeding. It is on my YouTube, but there are so many questions about bleeding, and it is so common that I just thought I would talk about it again. So bleeding is one of the commonest side effects of HRT. Many women experience bleeding when they start HRT. Now, I'm sure you realise that HRT usually contains estrogen. Estrogen can stimulate the lining of the womb. Progesterone normally works to thin the lining of the womb, and the balance of these hormones is important. And when we're having regular periods, or periods, they're not always regular of course, but when we're younger, what happens is our hormones estrogen and progesterone work together in a balance, and then as the levels of estrogen and progesterone drop, the lining of the womb shreds, and that leads to our period. So you can imagine, if you're having estrogen and progesterone as HRT, having the dose and type right can lead to regular periods. And often when people start HRT, if they're perimenopausal, so they're still getting symptoms, then we often start the estrogen, so it's every day, and the progesterone, so it's for 2 out of 4 weeks. And then in that time, every month, women normally have a period. It's usually a withdrawal bleed responding to the changing progesterone. But as you can imagine, if you're perimenopausal, you're still producing your own hormones. So if you're producing your own hormones and you're being given hormones, it might be a bit of a conflict going on. And this can cause lots of changes to hormone levels, and that can disrupt the lining of the womb. And so sometimes people find that they get irregular bleeding or persistent bleeding. And this can be more troublesome usually in the first 3 to 6 months of starting HRT. So it is important to know that patience is a virtue. We always warn people when they start taking HRT that it can take sometimes several months to settle down or settle into a routine if you're on the type of progesterone that you take for 2 out of 4 weeks. And that's often because the body is producing these hormones in different levels, and it takes a while for the womb to sort of work out what's going on. Sometimes the bleeding can be quite heavy when you start taking HRT, but it does usually settle, and obviously if it doesn't settle, it gets worse, you're getting other side effects, or you're concerned, then you should go and get it checked out, even if it's within the first 3 to 6 months. But generally it does settle within the first 3 to 6 months of starting HRT. Even people that have continuous HRT, which means they have progesterone every single day, and we usually start that when people are menopausal, so their periods have stopped for a year or so, and then we can give this continuous HRT, hoping that periods won't come back. But any type of HRT can lead to bleeding initially. So even if you haven't had a period for a long time and then you start a continuous preparation of HRT and get some bleeding, then don't be too alarmed, because it usually does settle within the first 3 to 6 months. Obviously, as before, if it's heavy, if you're concerned, if you have other systemic symptoms, then of course get it checked out. But usually it does settle. Now, having the right dose of estrogen is really important. As you know, we normally give estrogen through the skin as a patch or gel, and our skin is a barrier, so our skin blocks things from going into our bloodstream. Of course, when we put on a moisturiser or a sun cream, we don't want it going into our bloodstream. And so with the patches and gels, it depends on the skin thickness, the type of skin, the temperature of the skin, what the blood supply through the surface of the skin is, and how sticky the patches are, or how absorbent the gel is. Some people find the gel floats off their skin very quickly when they apply it, and of course they're not going to get that all absorbed into their body. Some people find that the patches don't stick on very well. My patches don't really stick on very well, and the glue is where the estrogen is. So if not all the glue is sticking to the skin, you're not going to get it all absorbed through the body. And I'm telling you this because there's always confusion about doses of hormones. What the dose is not equivalent to what's going in the body. So I know I put on my grid earlier this week that I use a higher dose of estrogen, and that's because when I used the maximum and standard dose, I just wasn't absorbing it enough through my body. My estradiol level was low, I was still experiencing symptoms, and my patches I could see were just not sticking very well to my skin. So using more than one patch means that the bits that are sticking are more, and therefore I'm receiving the right amount for me. Some people find that if their dose of estrogen is too low, as in they're not absorbing enough, it can cause bleeding. Everyone thinks that it's the high doses of estrogen getting into the body that increase bleeding, and that's not always true actually. And in our clinical experience, through the clinic, and we have a huge amount of experience, we find that actually sometimes when people are on a low dose and we increase the dose, it stabilises the lining of the womb and allows everything to settle, and so therefore bleeding can settle as well. So it's not always a matter of reducing the dose of estrogen, it might be increasing the dose. And that's where levels can be a useful guide. They are only a guide when we do estradiol levels, but sometimes if people have low levels and they're experiencing bleeding, we might try increasing the dose of estrogen. The other thing is looking at the dose of progesterone, because progesterone can absorb differently. A lot of people have it orally, but it depends on the metabolism. It depends on how it's digested through the gastrointestinal system and broken down by the liver. So the amount of progesterone going into our bodies will depend on our metabolism, on what we eat as well, or how long ago we ate, because eating can increase absorption of progesterone. Having progesterone on an empty stomach can actually reduce absorption. So we're all different. Some people use progesterone vaginally as well, and that means that more often gets absorbed through the mucous membranes of the vagina into the bloodstream. So if people are having bleeding, we also look at the dose of progesterone, and sometimes we'll increase the dose of progesterone, but not always. It's not a knee-jerk thing that a certain dose of estrogen has to have a certain dose of progesterone, and that's important when we're individualising dose of HRT. There have been some guidelines that have produced about bleeding from the British Menopause Society, and they've been endorsed by various colleges, but actually they're not based on solid evidence because the evidence and studies haven't been done. Sadly, when gynecologists see people in their outpatient departments for bleeding, they don't monitor people, as in they don't document, they don't use those results into research. And so there's lots of busy gynecologists across the country all seeing women who bleed on HRT, and they've done that for many, many years, but they haven't collected the data. So we haven't got, so great missed opportunity, isn't it? We don't know which women bleed more, which women bleed less, because we haven't looked at it, as in the gynecologists in the hospitals haven't looked at it. We've been looking in our clinic, and we monitor everybody who comes to our clinic, looking at the dose they're on, whether they have bleeding, if they have a scan. We look at what dose and type of HRT they were on, and what happened when they got referred to a gynecologist. And some of that data we're just writing up for publication now. Some of it we have written up as an abstract that was presented to the British Society of Gynecological Cancer earlier this week. Data is very reassuring, actually. We have very low incidences of endometrial cancer. In fact, when we look at the incidence of endometrial cancer in our clinic, it's less than background, which is the levels that you would expect, or the incidence that you would expect. And actually, that's the biggest reason that people worry about bleeding, is have I got a cancer or not? Because cancer of the lining of the womb, endometrial cancer, can present with bleeding. But most people who are on HRT don't have cancer. And in fact, all the research has shown that if women take a continuous preparation of HRT and have bleeding, they're less likely to have cancer than someone who has bleeding who's never taken HRT, which is really, really reassuring. It's a real nuisance when people bleed, and it's a real nuisance for the gynecologist to work out who needs investigation, what are the likelihood of having anything nasty going on. There are so many reasons for bleeding, and most of them are not related to cancer. So I've already said about fibroids. Some people can just have some thickening of the womb that can cause bleeding. Some people can have polyps, which are just little benign growths, which are quite easy to treat. Some people might have bleeding because they've got some vaginal dryness or some irritation in the vagina. And many people bleed because they've got this imbalance of their estrogen and progesterone when they take HRT. Some people have bleeding because they've got endometriosis or adenomyosis, which again needs exploring. Some people have bleeding if they're using a different type of contraception, like the progesterone-only pill or a combined oral contraceptive, or even if they've had a Mirena coil in, and they might start bleeding. Sometimes the Mirena coil can wear out, and that can cause breakthrough bleeding, or sometimes people can still have periods despite having a Mirena coil. In the perimenopause, hormone levels can fluctuate a lot, but they can be high as well as low, and that can cause quite a lot of chaos to the lining of the womb, causing some shredding and bleeding. And sometimes it can just be because the type of HRT has changed. So sometimes, for example, people find they change to a different preparation. They might change to a different type of patch, or from the patch to the gel, and the inconsistency in the way it's absorbed can trigger some bleeding as well. So it's not just if you start hormones and have bleeding, then you don't need to worry for the first 3 months or so. It's the same if you change the dose or type of HRT and have bleeding. You should give it a few months to see if it settles before being concerned about it. HRT really is important that it's individualised. For many women, it's been have this, if it doesn't work then just stop, and that's not always right. For many of us it can take quite a few months before we get the right dose and type, and certainly if we start it in the perimenopause, our own hormones are going to decline with time, and so what you think, oh great, I've just got it, I feel so much better, and then suddenly you might then experience symptoms, it's because your own hormone levels are declining, so you probably need more to make up for that deficit. And so it is really important that you are individualised with your dose. Some people are told that they have to stop taking their HRT if they're being investigated for bleeding. Now, there's no good evidence for this at all. Some of the gynecologists say, well, of course, if your bleeding stops when you stop HRT, then it's not going to be due to anything nasty at all. But actually for most of us, if we stop taking our HRT, it's going to be very difficult to function or to work because symptoms can often come back very quickly. I know if I forget to change my patches just because I've forgotten the day of the week and I leave it 1 or 2 days after I should have changed, I get worsening headaches, I get joint pain, I get muscle stiffness, I feel really tired, and I just can't imagine what it would be like if I stopped my HRT for 4 weeks. So we need to be thinking about what are the benefits or risks to that individual of stopping HRT for a short period of time. Mostly as clinicians, if someone has bleeding and we're concerned, we obviously take a good history, see if there's anything we can tell from what's going on for a reason. We might investigate the woman by firstly examining her to make sure that there's nothing obvious that's causing the bleeding. And then usually the first investigation is an ultrasound scan, and that's usually done through the abdominal wall, and then usually a very small probe is inserted through the vagina, and it's called a transvaginal scan, and it just means you can get really lovely clear pictures of the lining of the womb and the ovaries if you've got them. And then it's looking at what does the lining of the womb look like. Does it look nice and smooth? If it is thickened, is it irregularly thickened of the womb? And people measure the thickness of the lining of the womb, and in various guidelines there's different courses of action depending on the thickness of the lining of the womb. It is better to try and have the scan after you've had a bleed. So if you're having the cyclical HRT, have your period or your withdrawal bleed and then try and have the scan after that, because you can imagine if you have it just before you're due to bleed, then it's going to be thicker and that's going to cause confusion. So you're better waiting until the lining is at its thinnest. I've seen lots of people who have had a slightly thickened lining of the womb, nothing of any concern else going on in the scan, and then they've had a repeat scan a few months later and the lining of the womb has been quite different. So the lining of the womb can change. Sometimes it can change also depending on who's done the scan as well. And I found out recently that gynecologists don't automatically have training in doing scans, which is a great shame actually. So there's less people who have a lot of experience in scanning. So it's important to make sure, and it's worth asking, is the person that's doing your scan very experienced in doing gynecological scans? Because you want to make sure you have the best person doing the investigation and looking at the lining of the womb, looking at the whole womb in general, and often obviously looking at the ovaries and the surrounding tissues as well, and they can often give a really good picture as to what's causing the bleeding and help plan any other investigations. If the lining of the womb is thick and there's some concern or query about what's causing the bleeding, then people sometimes have a hysteroscopy and a biopsy, which is done by gynecologists. But they're quite safe procedures, but they can be uncomfortable. Obviously, it's more testing. There's always small risks of any procedure. So it's looking at the bigger picture. What are the real risks? Is it likely to be anything that might need further treatment or anything to be concerned about? Or could you repeat the scan maybe in a few months' time? Or maybe change the dose and type of HRT, maybe increase the progesterone, maybe consider having a Mirena coil. And the Mirena coil can be used with progesterone as well. So sometimes if we've got someone who has a slightly thickened lining of the womb, but it looks quite smooth, it looks quite homogeneous in the same texture throughout the lining of the womb, and we feel it's related to hormones, then we might change the dose and type of hormones slightly and then advise the person to have another scan, and then often things have really settled down, and we know that the risks of having anything nasty like a cancer in the lining of the womb are incredibly low for most women. So it's looking at each person very individually and seeing, because it's very hard when you look at guidelines because they're just guiding people for what the majority of women might need, but we're all different. I've also spoken to quite a few people who have had bleeding when they've changed just the pump. There were some things recently where the pump of estrogen gel wasn't providing quite the same volume, and women noticed that and then noticed they had bleeding. That's no surprise if they were using a different dose. And also, if they've been away, they might have forgotten to take the progesterone for a few days and then take it and then have bleeding. And so I wouldn't rush and investigate people if that's happened, especially with holiday season coming up. People sometimes find when they're hot, they absorb the estrogen through the skin more efficiently. Actually, when the skin is warm, you've got the lining of the blood vessels get dilated, they're more on the surface. That's why we flush as well. Obviously, when we're in the heat or our skin feels warm, there's more blood supply on the surface, so therefore there's more blood that is going to take that estrogen from the patches or gels, so then levels can be slightly higher. Then you come back to cold England and you don't absorb quite as much, and that can trigger some bleeding. So it does seem a bit weird to tell your doctor that you might have gone from a hot to a cold climate if you have bleeding, but it is worth exploring all have had bleeding when they're taking HRT, rather than just being put on a conveyor belt. So it's important that you can give the whole picture to your specialist. Some people who have bleeding, we often do iron levels, because if you have heavy bleeding that's persistent, it could be that you're losing iron as well, and obviously that can cause you to be tired. So having a ferritin blood test can be quite useful to give us a guide again whether you need to take an iron supplement, which will, and then obviously thinking about your nutrition. Are you getting enough iron in your diet? Because that's important if you are having bleeding that's prolonged and your iron level is low. Just finally, there are different types of Utrogestan. Certainly in the UK, there's something called Gepitrix, which is a type of Utrogestan that's just been made by another company. It looks the same, it contains the same ingredients, but we have found that some people find that they don't tolerate it as well and maybe not absorb it quite so well. And that is probably the way it's been made. And so maybe it's just the way the capsule's made. I don't really know. But if you are getting some bleeding and you've changed what you think is like for like with your HRT, but it's got a different label on it, then it might again affect the absorption. So it's just worth bearing that in mind, because often if it's such a coincidence and you think, well, yeah, there's nothing else that's happened, I've suddenly got bleeding out the blue, hang on, I was given a different label, a different name of the prescription that I've been on for many years, then it could be that's triggered it. Mostly, as women, if you have bleeding, you often know whether it's likely to be related to something more serious or not. And some people say, oh, I just feel like it's my period. I get some cramps, I get some breast tenderness, I feel a bit bloated, and then I get a bit of bleeding for a few days, which then stops, and then it happens a month or so later. Well, it's very unlikely there's going to be anything serious with that, and so often you can just monitor and see. So what I'm trying to say is that if you have bleeding and you're taking HRT, there are a myriad of reasons, but thankfully the studies have shown that it's not usually related to cancer. So speaking to someone who doesn't just knee-jerk refer you, but actually takes a really good history, looks at whether you can optimise or alter or tweak your HRT, and then seeing if your bleeding settles might be the best option for some of you. So I hope you found that helpful. I'm going to share some resources on my story now, and I hope you enjoyed the evening. Thanks for tuning in.